Thank you, Sam. It's great to be part of this symposium. I'm going to try to start my screen sharing here and get this presentation up and running. I hope everyone can see that and they're only seeing one screen. Look okay?
Looks
good. We've got a great lineup today, and we've got lots of time to take questions because we want to make sure that in the end we address the issues that are most important to you, the audience. So a number of different speakers from Moffitt Cancer Center are going to talk about a whole range of topics relevant to adults and children with melanoma. And if anybody in the audience didn't know that children got melanoma, they'll find out before this symposium is over that unfortunately it is the case. So again, please send your questions into the chat, and we want to answer everybody's questions as best we possibly can. I'm going to begin by first talking about what's new in the surgical treatment of melanoma, and then we're going to go from there. These are my disclosures of relationships with industry. And now I want to disclose that melanoma is a really, really big problem, and it's getting bigger all the time. The incidence rates just keep going up. Over 100,000 invasive melanoma cases and an equal number of melanoma in situ cases. So over 200,000 cases in the United States this year in 2021, nearly 10,000 invasive melanomas in Florida. We here in Florida have the #2 state in the country. Sam there in California is in the #1 state, but no place in the United States, not even Alaska, is immune to having cases of melanoma. And these numbers, especially for the earliest melanomas like melanoma in situ, are probably dramatic underestimates. But even with that, even with the warning that some of these numbers are an underestimate, the prognosis is alarming. This graph shows the expectation of the rise in the number of melanoma cases shown in this black dotted line compared to every other type of cancer, excluding basal and squamous skin cancers, because they're so common, they would be up on the roof somewhere if this graph was carried higher. This pink line is breast cancer, and what you see is by 2040, melanoma is expected to be the #2 form of cancer in the entire United States and #1 in males. That's not the #1 we want it to be, but that's the #1 we're going to find ourselves as. That melanoma is the most common form of cancer in males, not counting all the other skin cancers, and the #2 in women, the #2 overall in the United States. So as busy as we are today, we're expecting twice as many cases of melanoma just 20 years, from now. Now, I'm going to start by giving you all the answers to the quiz, everything I'm going to talk about, and then also spill the beans on what some of the other people are going to talk about. So I'm going to talk about where we are in melanoma, what the changes have been, and how that impacts whether sentinel node biopsy still has a role to play in localized melanoma. Spoiler alert, the answer is yes. Should sentinel node positive patients have a lymph node dissection? No, and we'll talk about why not. And should they get adjuvant therapy? Should they get something once it's in the lymph nodes to keep the melanoma from coming back? Most of the time, not always. And lastly, I'll talk a little bit about what we're doing to study gene expression profiling tests that look at the expression of genes in the tumor to determine whether this is going to be useful in the future, because we don't think it's quite ready for prime time for just everybody to use. And then here are some of the other things we're going to hear about. We're going to hear about progress in stage 4 cutaneous melanoma, where we've made amazing progress in the last 10 years. even though those incidence rates I talked about are skyrocketing, the death rates actually going down. We're making big progress. Are we making the same progress in uveal melanoma? Dr. Tarhidi is going to tell us we're making some progress, but we really need to catch up to what we've done in cutaneous melanoma. And then Dr. Messina is going to tell us what's new in pediatric melanoma, just about everything. And we're really excited to have Christina McNamara back with us. She's one of our social workers, and she's going to talk about how we live with and after melanoma. So first, sentinel node biopsy. What do we currently recommend at Moffitt for using a sentinel node biopsy, and why? And a lot of this is doctor speak, so bear with me, but I think it's important. Sentinel node biopsy is indicated. That means it's what we recommend as the standard procedure for any otherwise healthy patient with melanomas that are at least 0.8 millimeters thick. So a little trick question. Many of you may have looked at your path report and saw that yours was a 0.72 or a 1.04. The new reporting rules call for rounding down to just one decimal place. So 0.8 is really 0.75 to 0.84, but we abbreviate that as 0.8 millimeters thick anywhere on the body. And that, as the asterisk tells us, is based on the fact that overall, once you get to that 0.8 millimeter thickness, there's at least a 5% chance that the melanoma has already spread to the lymph nodes. And that's the threshold. That's the tripwire for us to say we need to know what's in that sentinel node. Why? Because if we know what's in the sentinel node, we get reliable staging information. What's that mean to a doctor and a patient? It means a much better sense of how likely that melanoma is to ever reoccur. And we get that staging information with low morbidity, not zero, but comparatively low side effects, most of which go away within a few weeks or a few months at the most. And very importantly, if we tell you your node is negative, most of the time, that's really accurate. It's not 100%, no test in medicine is, but there are very few false negative results, meaning we tell you your node is negative, but there's really another lymph node in that same part of your body just waiting to show up later on. It does happen. Fortunately, it's rare. Now, this is a tricky part. We think sentinel node biopsy may have therapeutic value for sentinel node positive patients. What does that mean? It means taking out that sentinel node about half the time or more. That's the only place the melanoma has spread to. So getting rid of that actually cures the problem. Doesn't just stage it, but actually treats it. We now have learned we don't have to take out all the lymph nodes to cure some people with node positive melanoma. And in fact, today, our focus is on curing as many people as we can, but decreasing the need for lymphadenectomy. What does that mean? Doing the fewest complete lymph node dissections we can. Because while we've gotten much better at doing lymph node dissections and minimizing the side effects of lymph node dissections, the chance of lifelong side effects like lymphedema, swelling of the arms, swelling of the leg, with a lymph node dissection or a lymphadenectomy, as we call it in the medical terminology, is much, much, much higher than the chance of any kind of permanent lasting side effects like lymphedema if we only do a sentinel node biopsy. So we want to stage people, find out what their odds are of being cured. We want to increase their chance of being cured. We want to decrease the need for a long-term negative outcome. And sentinel node biopsy today still does all of those things for our patients. And we do it on anybody if we think they have at least a 5% chance of having a positive node and they're healthy enough to have the procedure. But that's not everybody, because some people older patients and those with a lot of medical problems, we call them comorbid conditions, they probably should have a higher threshold. And we actually bump it up a little bit and say, I don't want to do it on just a 5% chance. I want a higher chance. Sometimes we don't do it at all. We think the risk of the surgery is too great. And here's why we still do the procedure. This information is really important. It's useful, it's meaningful to patients. And here is data that's now many years old, but it stood the test of time. This data shows that if your lymph node is positive, your sentinel node is positive, your chance of a recurrence within 5 years and within 10 years is much, much higher than if your lymph node is negative. Now, if you're smart and you're carefully looking at this, you notice that not everyone who's got a negative node is cured. Some people have a false negative node, like I talked about. Other people, the melanoma bypasses the lymph node and shows up somewhere else. And in the very, very near future, I think you're going to hear more and more about potential treatments for patients with sentinel node negative melanoma, thick sentinel node negative melanoma, to try to capture some of those cheater melanomas, the ones that are escaping the sentinel node procedure. But if you have a positive sentinel node, even though your outcome is not as good, it's still better than it used to be, and it's better than it is if you let the melanoma reoccur in the lymph nodes and don't do anything until that happens. So should those people who have a positive node have a node dissection? And the answer here was initially, yeah, we thought everyone should have it, because here in this original study, everyone with a positive node had a lymph node dissection. And everyone who didn't have a sentinel node biopsy, their melanoma came back, then they had a node dissection. They didn't do nearly as well. So clearly there was a value, but was it from the sentinel node that was improving this outcome? Or was it from the lymph node dissection? How much was able to be achieved if we only performed the lymph node biopsy and we didn't do the node dissection? Well, here's what we've learned from now 2 large randomized trials, heroic trials with heroic patients who are willing to let us flip a coin. Heads, you have a node dissection, you take all that risk of lymphedema. Tails, you don't have a node dissection, you walk around thinking, gee, do I have a ticking time bomb here? Should I have had surgery? Did I miss the boat? Well, the blue line is what happened to the people who did have a lymph node dissection. Those people, 90% of them never had any other recurrence in their lymph nodes, only in the place where the surgery was. And on the red side, the red line, 70% of them never had a reoccurrence in those lymph nodes. This is only the lymph nodes, only the region where the sentinel node was. So yes, doing the lymph node dissection caught some additional nodes and kept them from becoming enlarged. But did it really make a difference in the long run? Well, here, now the red and the blue lines look almost identical. In fact, if you were red-blue colorblind, you couldn't tell them apart, and it wouldn't matter, because what this showed was if we were watching people carefully, and for that small group who did have a regional recurrence, we could operate on them quickly, then the survival was equivalent if you just had a sentinel node biopsy and we observed you carefully for a lymph node recurrence versus going through the complete node dissection surgery. And this wasn't just one clinical trial, so actually 2 clinical trials. Here again, even the colorblind can tell that there's no difference between having the completion lymph node dissection surgery and nodal observation, with the important caveat that all these people were followed very, very, very closely and had surgery as soon as something popped up in that small group of people who did recur, excuse me, in their lymph nodes. And so once the lymph nodes become clinically positive, once that sentinel node biopsy patient goes on follow-up and does show up with a lump, or if a person comes in right off the bat with a lump in the lymph node, now a lymph node dissection is indicated. It is needed at that point, but most people need systemic adjuvant therapy, drugs to keep the melanoma from coming back, and some need radiation. And if you're going to have drugs anyway, maybe we should use the drugs first and do surgery later. That's called neoadjuvant therapy, and we're doing that a lot for our patients with enlarged lymph nodes today. So we try to do a needle biopsy, not remove the lump. People say, well, get that lump out of there. No, get a needle biopsy, figure out what it is, and then let's figure out what to do first, because it's no longer a question of what to do. It's now a question of what to do first when the melanoma has developed into a mass in the lymph nodes. Again, most people with a positive node should get adjuvant therapy, but there's limits to what we can do with adjuvant therapy. Some people, illustrated up on the top in blue, their melanoma comes back despite getting a year of treatment. Some people never had their melanoma come back with no therapy. They could have gotten by without all those side effects. And only a percentage, right now we think about 20% of people are benefiting from adjuvant therapy, but everyone has to get treated because we can't figure out yet who those people are. We know they're benefiting, but we don't know who is the one that's benefiting. So who don't we want to give treatment to? I said most people. We look at the size of the melanoma, not on the skin, but in the lymph node. And we're paying a lot of attention to that nowadays, because as you see here in this graph, in a study we did in conjunction with some of our colleagues in England, when the melanoma in the sentinel node was less than 0.3 millimeters, and there were other favorable factors, it was almost as good as not having anything in the nodes at all. And so we didn't need to do treatment for them. We can focus on the patients with higher risk. But really, we want to get even better at figuring out who needs treatment. And that's why there's a lot of interest in molecular tests, in gene expression profile tests, try to predict from the genes of the tumor which patients need a sentinel node biopsy, which patients need adjuvant therapy. There's a lot we could learn from these genes, but we're not quite ready yet. We'd like to figure out which patients with really thin melanomas, who we're currently saying you don't need a sentinel node biopsy, should have it. We'd like to find which patients with thicker melanomas don't need a sentinel node biopsy. And we need better ways to figure out who has a positive node than the ones we've been using. And at Moffitt Cancer Center and at 10 other places around the country, we have started on a large clinical trial. Over 2,000 patients will all get this a specific gene expression profile test designed to see if we can predict whether or not the lymph node is positive. Everyone gets a sentinel node. No one knows what this gene test shows, not me, not the pathologist, not the patient. But at the end of 2,000 plus patients, we will know whether we can do this going forward in the future. We also want to test, can we figure out, this is a different way of showing you the same thing I showed you before. Some people died despite the treatment. Some people were fine without the treatment. Only a few in the middle really benefited. Can we figure out who they are with the gene expression profile? Unfortunately, a big study just last year said we can't really do that yet. We can't predict at present who should have adjuvant therapy based on gene expression profile tests. And a large national cooperative analysis that I was part of said at the present time, we just can't depend on these gene expression profile tests. We need to do more research on them, and that's exactly what we're trying to do here at Moffitt. So that's basically where I'm going to stop, and we're going to turn over to some of our other speakers to continue the process. And then at the end, we're going to have a panel discussion led by Karen Smalley, our head of melanoma research, so that we can cover everybody's questions.